So I want to step back a little bit and kind of talk about something that you mentioned in one of your presentations. Like I said, you mentioned this 2002 NEJM study showing pre-existing mutations in chronic phase CML. How did the discovery change your how we approach TKI therapy today?
No, that's 25 years ago. That's a long term, but it's important because it's an example for resistance mechanism in cancer in general. That means the more specific you are against a cancer cell, the more methods, genetic methods, find the cell to escape this selective pressure. And we found this very early in the imatinib development, that a patient who does not respond optimally to imatinib, that means to have a higher tumor load over time, will have mutations eventually. And this was found in CML, but also in GIST, for instance, which has been treated inhibiting the KIT gene with imatinib in the same way, but in a solid tumor in this case. That means it's a general phenomenon that the molecular targets may escape with point mutations, who then grow up either in the tumor, like in GIST, but also in the bone marrow and the peripheral blood, like in leukemias. And of course, it was important to detect the reason for resistance and to find a way to overcome it. The first way, which we did 25 years ago, was to stop the targeted therapy and to go back to chemotherapy, which is not needed anymore because we have more targeted options available now. We could use the second generation drugs, we could use ponatinib, and we can now use new drugs like the myristoyl site inhibitors, most importantly, of course, Asiminib, which inhibits the cancer cells on a different position and are therefore a very good option in late-line therapies for resistant patients. Asiminib is a BCR-ABL specific inhibitor. That means it does not inhibit other kinases, therefore much better tolerated than any multi-kinase inhibitor. And it can be used as a monotherapy. This has been demonstrated in late-line therapies, led to the registration of Asiminib in most countries worldwide for third line. But now we have the studies available in first line, ask for first and ask for start studies. And we know and we have proven that we can use this monotherapy in first line, which is very efficacious, more effective than imatinib and more effective than second generation inhibitors, has been demonstrated in two studies, ask for start and ask for first. And it's better tolerated. And this is proven now.